Greetings, I'm Dr. Sonbo of Basic Master Course Director. I am honored to be with you here today. Today I want to talk about pre-op surgical prep. Pre-operational surgical preparation has immense impact on surgical results. So what is the surgical result that we desire? A smooth surgery that ends quickly. A smooth and quick surgery with good results, with little fatigue. If this can be realized, then both the surgeon and patient will be satisfied. If you do good surgical setting, you'll be able to realize this even better. You need to have appropriate setting in your surgical room to get a satisfactory surgical result. Light source tools assist. These three areas need to be heated. If you look at my surgical room, I use a surgical light that provides sufficient light, and I allocate different tools and kits that befit the surgical flow. I work with an assistant who is well-trained and knowledgeable on the surgery. A shadowless surgical light is not imperative, but if you can have this, then you can get a better visibility. If you plan to buy it, 2-axis shadowless surgical light can be limiting in terms of movement. Therefore, my recommendation is to use 3-axis arm shadowless surgical light, but this can be affected by the height of the ceiling, so you need to check this before making purchase. All implant placement surgeries involve open surgery. If you ignore the fact that this is open surgery, then problems can occur, like cross-contamination. Even if the surgery has been completed wonderfully, we might have to remove the implant because of cross-contamination. Therefore, thorough sterilization is imperative. You need to prepare a kit and tool that has been sterilized. You need to use a sterilized surgical glove and gown to prevent cross-contamination. We also need to make sure that there's no contamination due to the patient's own contaminants. Also, attention should be paid so that there's no post-op contamination. In my case, if there's a patient that is about to go through implant surgery, I always check the overall perio condition. If there's moderate level of inflammation in the patient's periodontal state, then I would take precautionary measures such as scaling before surgery in order to make the inflammation become reduced. After that, the surgery is proceeded because if you perform surgery with inflammation unaddressed, it can cause the post-op inflammation or it can cause hindrance to healing process. On the day of surgery, once the patient comes in, you need to clean the surgical site thoroughly before applying the sterilized drapes on top of the patient. Around the surgical site, you remove the plaque and calculus thoroughly, as shown on the image in number 46 and 47. If implants are planned, at least number 45, 44, and anterior area needs to be cleaned. Next is intraoral and extraoral sterilization. For intraoral sterilization, I use 0.12% chlorhexidine. I have the patient mouth rinse for about 1 minute. This is to reduce intraoral bacteria to control sources of contamination. In the case of extraoral sterilization, I use betadine to sterilize patient's skin. As shown on the image, you do sterilization doing outward spiral movement. Sterilization effect kicks in as it dries, so you need to tell the patient that there can be a tingling sensation on the skin. After that, surgical drape is applied on the patient. The kind of drape that we use when we provide a general treatment, there are limitations to it because it cannot cover the patient's chest and arm. You need to have a surgical drape that can cover patient's chest, belly, and arm. It needs to be sterilized, and there can be contamination if it is wet, so it is not recommended. In the surgical set, you need to include 5 sets of sterilized aluminum foil and use that foil to cover areas where you can touch during surgery. For instance, it can be light handle or handle of shadowless surgical light, and you should also cover the handle of the surgical cart and the surgical table. You adjust the light most frequently. The handle of the light needs to be covered on both sides rather than doing it just on one side. This is more advantageous because both surgeon and assistant can manipulate the handle. If you have a shadowless surgical light, you cover the handle with a foil. In the case of shadowless surgical light, the handle can be separated, so you can use autoclave on it. In that case, you can use it after using autoclave. This is a sinus sleeve that covers the handpiece hose. This is a vinyl where you can do sterilization and you cover the handpiece hose with it. As for handpiece, it goes on top of sterilized drape, so you need to cover the hose area with foil to prevent contamination. The image shows the setting of the surgical room. Personally, I use 2 carts. The main cart is positioned in the 12 o'clock direction of the patient. The sub-cart is positioned either on 9 o'clock or 8 o'clock direction from the patient. There are major tools necessary for surgery in main cart. In sub-cart, there are tools necessary for making incision in the early stage of surgery. There is also implant engine and implant handpiece. This is the actual surgical room as mentioned. There is main surgery cart in 12 o'clock direction, and depending on the situation, in 8 o'clock position, there is the sub-cart. Next, I'm going to talk about the surgery posture and position. Even if the same treatment is provided, depending on the position of a surgeon and patient, visibility and accessibility differ, so it can affect the surgical fatigue on the part of the surgeon, and it also determines the length of surgical time. Let's look at position for the upper. Compared with lower, the unit chair should be set as higher, and the angle of the unit chair should be close to supine. As for headrest, it should be laid down. Some people say that if you have the patient in close to supine position, patient feels discomfort and suffers, but personally speaking, making surgical time short would reduce patient's discomfort. I think that holds more significance. You have the patient lift the chin towards the ceiling, then you can get the good visibility. Treatment is performed in upper right. The surgeon approaches from 9 o'clock direction and the patient is facing forward. You need to make a request ahead to the patient so that the patient's head does not turn right when retraction is done. The assistant uses left hand for suction, and with the right hand, retraction is done. Let's expand this image. The position of the surgeon is from the corner of the mouth. Minnesota retractor is used. You can guide flap, cheek, and lips at the same time. The assistant uses dental mirror and guides the lip from the frontal position so that there is visibility. This is upper left case. The surgeon approaches from 9 o'clock direction, and the patient faces slightly towards the right side. And you need to make request ahead so that the patient's head does not move left upon retraction. As for assistant, with left hand, suction is done, and with right hand, retraction is performed. The difference between upper left and right is that assistant's dental mirror is positioned in the corner of the mouth to secure visibility. In front of that dental mirror, the Minnesota retractor of the surgeon is positioned for guidance. As you can see, sufficient amount of visibility can be secured. This is the setup of the upper anterior. The patient faces forward, and if the patient positions the tip of the chin towards the ceiling, then the surgeon can get good visibility. The surgeon approaches from 11 o'clock direction. Assistant uses left hand for suction and right hand for retraction. This is an expanded image. The surgeon's Minnesota retractor is guiding the right half of the upper lip, and the dental mirror of the assistant guides the left half of the upper lip. Next is the position for the lower. The height of unit chair is comparatively lower compared with when treatment is performed in the upper, and the angle is slightly more upright. You have the patient bend their neck towards the chest. This is a lower right case. The surgeon approaches from 9 o'clock direction, and the patient faces the front side, and you need to make a request ahead so that the patient's head do not turn right upon retraction. The assistant uses right hand for suction and left hand for retraction in this case. This is an enlarged image. The Minnesota retractor is positioned in the corner of the mouth for guidance, and the dental mirror of the assistant is positioned in front of that. This is a lower left case. The surgeon is positioned and approaches from 11 o'clock direction, and the patient is asked to look slightly towards the right side. Request is made so that the patient does not turn their head left way upon retraction. The right hand of the assistant does a suction, and with left hand, retraction is performed. This is an enlarged image. The surgeon uses Minnesota retractor to provide guidance from the corner of the mouth, and the dental mirror of the assistant is positioned in front of that so that visibility can be gained. Next is lower anterior position. you have the patient bend their neck so that they can head towards the chest to the fullest, and the surgeon approaches from 11 o'clock position. As for the assistant, suction is performed with right hand and retraction with the left hand. This is an enlarged image. Minnesota retractor guides the left half of the lower lip, and the assistant guides the right half of the lower lip. This is a table where it summarizes how the surgeon should approach the suction direction of the assistant and guidance from the corner of the mouth. If you're a little bit confused, you can use this table and apply it in your surgery to get good visibility and perform good treatment. In offline master course, you can find out even deeper details, and you'll be able to really get your hands on practical information. Those who have just begun implant treatment or who wish to improve upon their implant treatment can refer to master course. I think that'll be the optimum choice. I look forward to your keen interest.